you made a very important point that actually a key secondary endpoint was the incidence of neuropathy. And I think that that was met comfortably with a highly statistically significant reduction in the severity of neuropathy for the 3-drug arm compared to the 2. And that, I think, was, again, a very crucial part of the design of the study, because what we were able to demonstrate was that the weekly bortezomib preserved efficacy with selinexor. But most importantly, we were able to reduce neuropathy. And there may have been more than just simply the weekly administration in the mix, because there is compelling preclinical evidence that selinexor may have anti-inflammatory effects. And in the context of reducing these inflammatory signals, this may have a favorable import on the incidence and severity of neuropathy, something we've known for many years in our studies with bortezomib. Hence the importance of partnering bortezomib with dexamethasone on the day of administration, the day after. It was very nice to see in this study that, in fact, the addition of selinexor with this weekly schedule substantially reduced neurotoxicity. Now, having said that, there were still obviously side effects to the 3 drugs compared to the 2 that were important. And I think the GI toxicity was there, but much less severe and less challenging and much less broad in terms of overall numbers compared to the challenges we saw in STORM. I think it's worth sharing, though, that in the study, we were dealing with centers who were relatively inexperienced, with selinexor certainly. And at the same time, in the protocol, we were very permissive, and we recommended supportive care, obviously in the form of ondansetron and so on, but recognizing that in the international setting, prescriptive strategies for antiemetics could be more challenging. We left it very much at investigator discretion as to how readily they might use, for example, olanzapine, depending on availability in the countries where the study was being performed, and so forth. In any event, I think that's why I feel very sort of confident in the results from Boston, because they essentially reflect what you so nicely put was real world practice. One of the things I meant to ask you was, I was particularly struck by the efficacy seen from selinexor in high risk, and I thought that was particularly impressive.
Yeah, I think so too. I mean, we are always looking for this combination and to determine if there is a difference between high risk and standard risk. Of course, in a relapse setting, it's a little bit more confusing because now we're dealing with patients with more resistant clone, probably some changing on the clone. So we see the number of patients with high risk included was pretty high, and there was no difference in response. And I think it's absolutely important when we choose the right combination for the right patients based on comorbidities, type of myeloma, prior lines, and also cytogenetics. I think is very important. I would love to see a dissection, you know, between the deletion 17, the different translocation. Like we know that bortezomib and the proteasome inhibitor are performing very well with the different translocations in chromosome 14. So I would love to see a dissection. Unfortunately, it's difficult sometimes because some of these genetics, they come together. But I love to see that, and yes, absolutely. I think that a very good combination, also targeting some patients with more aggressive clone.
Well, I think that's right, and I think the hazard ratio being so striking for the high risk group really sort of reinforced in my mind anyway what I've always been impressed by from the very early days when the preclinical development of selinexor was the observation made about its effects on 17p deletion. So very, very gratifying to see. I think the other thing that struck me as well is you pointed out very nicely that in the elderly, the frailty index was formally assessed and the hazard ratio for benefit was preserved. That, I think, was really important information because that basically said, look, this isn't a drug that just has to be reserved for the Lance Armstrongs of our patients, if you'll excuse the metaphor. You know, it's a drug that can be legitimately offered to older patients. And in fact, in the STORM study, one of my patients who actually derived significant benefit from selinexor and actually hadn't responded to anything else for that matter until he received selinexor was 86. So I think this group of patients in whom you know, that this can actually help the elderly is very important. So I think that was also suggested by another very interesting observation, which was in the group of patients entering the study who were actually proteasome inhibitor naive. Because remember, this was first relapse and beyond. So
Right.
patients had to be, they could be exposed to a proteasome inhibitor, but they had to be obviously responsive. They couldn't be refractory. That would have not allowed equipoise for the control group. But in the patients who had never received a proteasome inhibitor, in other words, older patients just receiving immunomodulatory treatment, such as lenalidomide and dexamethasone, the hazard ratio there was really impressive. Because you might say, well, for those folks, does PI with dexamethasone do just as well? No, it didn't. Actually, the three drugs really did perform better, and the hazard ratio was quite striking for that group. So I think we've got the highest level of evidence from a phase 3 multi-center international trial with true real-world characteristics to demonstrate efficacy.